give a special welcome to our last two speakers of the day. They are both senior counsel at Husch Blackwell, Rebecca Rodman and Renee Zerbonia.
Thank you. Thank you, Angela and Stephanie. Hello, everybody. We'll pull up our slides and get started. It sounds like Angela just introduced us, but we are attorneys with Husch Blackwell who work regularly with healthcare providers and pharmacists on 340B issues. We're going to go through our presentation and save some time at the end to answer your questions. If you want to put them in the chat while we're speaking, please feel free to do that. But I think we'll wait till the end to answer them. So thank you. We're glad you're with us today. We are going to go through 340B, give you some background, discuss legal developments and impacts, and discuss preparation that you might want to take in response to issues relating to 340B. Can you forward to the objective slides? Thank you. So the objectives for today are to describe the federal 340B program, participant eligibility, how it operates within the drug supply chain reimbursement system, and the obligations of pharmacies that dispense 340B drugs. We're going to discuss legal developments in the 340B program and how you can respond to potential future changes, including how to make sure you can maintain compliance and optimize your care. And I think, Renee, you're going to take over the next bit.
Yeah, here. We can just run through the agenda again real quick. I think Rebecca covered a lot of this. We're doing some background on 340B, role of pharmacies in the program, legal developments and impact, and then pharmacy preparation and response. So let's get started with a bit of background on the program. We want to kind of tee up what it is, why it's important, the different entities involved in the program, and how pharmacies come into play. So for some general background, the 340B program, it's really a drug discount pricing program that was established in 1992, and it requires pharmaceutical drug manufacturers to sell their products to eligible healthcare organizations at these significantly discounted rates. These eligible healthcare organizations that can qualify for these discounted drug prices are typically safety net providers, those that serve, large, low income or underserved patient populations, and really kind of provide a vital role in caring for certain groups of people out in the world. And so that's kind of what this program is. The purpose behind the program is, you'll see here in that second bullet point, you'll see in the legislative commentary, it talks about, the goal being, we want to allow these safety net providers to stretch their scarce federal resources so that they can reach more eligible patients or provide more comprehensive services. So it's kind of intended to provide financial assistance to these safety net providers that service these vulnerable patient populations. How it does that is by purchasing these discounted drugs. The covered entities or safety net providers are then able to, when they submit claims for dispensing those drugs, receive full reimbursement from payers, as they would had they purchased the drug at the typical price. So you're seeing a much larger profit or return in revenue there through the payers. And the program, part of the reason we wanted to talk about this program today is it's been a huge subject of debate, particularly in recent years, as there's been a lot of growth in the program. We're seeing, millions and millions, billions of dollars being purchased in discounted drugs under the program. And we see kind of two sides here. We have supporters who are arguing that this is a critical program for these safety net providers. It helps them maintain their financial viability when they're operating on razor thin margins, helps them serve the people who need to get care the most. Critics, on the other hand, are saying that the program's really ballooned beyond its original intent and that it can lead to sometimes increased drug prices. All right, so before we dive into kind of more of the specifics of the program itself, we wanted to tee up some history so we know where we stand and understand kind of why this program was created and the context there. So in 1990, Congress had passed legislation that was requiring drug manufacturers to enter into rebate agreements with the government for their drugs to be covered under the Medicaid program. So essentially, if a manufacturer wanted their drug covered under a state Medicaid program, they had to agree to offer drug rebates to those state programs. This is referred to as the Medicaid Drug Rebate Program, or MDRP. This had an unintended consequence, however. So it did kind of achieve a goal of offsetting the government spending and Medicaid on some of these drugs, but it ended up increasing provider costs for other typically discounted drugs. So you can see that, okay, we're having these certain federally funded clinics, certain safety net providers. They're like, wait a second, our outpatient drug cost is increasing. So as a response in part to that, Congress created the 340B drug pricing program. It's essentially named after the section of the act in which it was created. So it's just section 340B. And as a result of this legislation, drug manufacturers are required, as a condition of participation in the MDRP, to also participate in 340B. So what that means is essentially, if a drug manufacturer wants to have its products reimbursed and covered under the state Medicaid programs, then they must participate in both the MDRP and offer back-end rebates, as well as participate in the federal 340B program, where they are offering those upfront price discounts to covered entities. Oh, and one additional comment before we move on to the agency slide is the statute itself is fairly sparse. It's a pretty complicated program. The statute, there's not too much to it. So it can lead to a lot of confusion and kind of some issues in the administration of the program. Adding to this is the fact that HRSA, which is the Health Resources and Services Administration, which is the agency charged with implementing the program, really has limited rulemaking authority. So it can't, define terms via federal rulemaking that it may otherwise want to define. Its rulemaking authority is really limited to 3 aspects of the program, which are the administrative dispute resolution process, which is the process by which disputes between the safety net providers or covered entities and the pharmaceutical manufacturers are resolved. It can issue rules on the calculation of the discounts or the cap on price, as well as the civil monetary penalties on manufacturers for violating the terms of the program. And then going back to this slide here, you'll see that the administrative agencies that implement the program and operate the program are HRSA. And then within HRSA, we have the Office of Pharmacy Affairs, or OPA. And another party that you'll see mentioned as well is Apexis, which is the 340B prime vendor. They are a contractor that has contracted with HRSA to implement some portions of the program, and they provide things like 340B education. They assist with price negotiations, and they offer technical assistance to the stakeholders in the program. All right, so to talk a little bit about the drug pricing under the program and where these discounts come into play, you'll see that the maximum price that manufacturers can charge a covered entity under the 340B program is referred to as the ceiling price. That ceiling price is calculated quarterly by HRSA, and it amounts to the average manufacturer price, or AMP, less the unit rebate amount, URA. And there are also opportunities to obtain sub-ceiling pricing through the prime vendor program, which, as we mentioned, is operated by Apexis. Okay, so let's go back and talk about kind of the scope of the program and some of the key terms here. The program, again, it's discounted drug pricing, which is available to those safety net providers, which are defined in the statute as covered entities for outpatient drugs dispensed to eligible patients. So I'm going to skip the first bullet and go straight to the covered drugs. So a covered drug under the 340B program is limited to drugs in the outpatient setting. So a drug, dispensed to a patient while they're inpatient at a hospital will not qualify for the discounted pricing under 340B. It's only available for outpatient drugs. There are certain other types of drugs that can qualify, certain over-the-counter prescriptions written by providers or prescribers, certain, biologics, insulin. But again, it's outpatient drugs. We're not talking about inpatients. We're not talking about vaccines and things like that. When we're on the issue of a covered drug too, what's interesting to note is that whether a drug qualifies for 340B eligibility is not dependent on the type of drug necessarily as much as the setting. So again, if inpatient versus outpatient, the same drug dispensed to a patient while inpatient at a hospital, that it would not qualify, while that same drug, if it's dispensed in the outpatient setting, will. And another thing to note on covered drugs is that when they are dispensed, patients do not know that the drug they're getting, they don't know if it's a 340B discounted drug or just a regular drug. It doesn't necessarily flow down to the patient, and that discount does lie in the purchase price that's paid by the covered entity. Okay, so covered entities, these are the types of safety net providers that qualify for those discounted drugs. These are set forth in statute. They're defined under the program. You see categories of hospitals, including disproportionate share hospitals, critical access hospitals, and so forth. FQHCs, different types of grantees, including Ryan White program grantees and certain specialized clinics. Hospitals, you see, make up the vast majority of the 340B purchasing, particularly the disproportionate share hospitals. The hospitals make up about 70% of the covered entities and take up about 90% of 340B market share. And then within that, again, the disproportionate share hospitals take up the largest share there. As far as eligible entities, requirements, they are required to register with the Office of Pharmacy Affairs Information System. They have to be approved by HRSA, that they are in fact covered entities under the statute and fall within one of those designated categories. And they have a few notice requirements as well for manufacturers. All right, so the last bucket here of those terms that we looked at on the previous slide are eligible patients. So under the program, 340B covered entities can only dispense these covered drugs or drugs purchased at this discount to eligible patients. And specifically, you'll see under 42 USC 256B, where that comes in is they are prohibited from reselling or otherwise transferring a drug to a patient to a person who is not a patient of the entity. When a covered entity is looking at who's a patient, this is a hot topic right now. Congress did not define the term. It was left undefined. So what happened was HRSA has issued some guidance back in 1996. And remember, this is guidance because they have limited rulemaking authority. So they've issued guidance to provide some clarity on what they consider a patient to be with respect to 340B. They set forth some eligibility criteria that kind of walk through when someone is considered a patient of that covered entity. And that would be when the covered entity has established a relationship with that individual, such that they maintain their healthcare records. So one, are their healthcare records being held by the covered entity? Does the individual who's receiving the healthcare services from some healthcare professional at the covered entity, is that healthcare professional employed by the covered entity, or are they under some sort of other contractual arrangement such that the responsibility for the care lies with that covered entity? So typically here we're looking for an employed healthcare professional or someone under contract with that covered entity. This third item is not applicable to disproportionate share hospitals, but for your grantees and other covered entities, does the individual receive a healthcare service that's essentially consistent with the services that the grant funding was issued for, or that FQHC lookalike status has been provided? So again, if you're a grantee, are you providing the typical expected healthcare services under your grant to this person? And there's a few things that, a few items that make someone not a patient, things to consider here. So an individual is not considered a patient if the only healthcare service that they are receiving is the dispensing of the outpatient drug. So there has to be some other underlying service being provided in connection with the 340B drug itself. You can't, as a patient, go solely to get your outpatient drug, dispensed through that covered entity. That's not going to count. And something to note too here is that when we're talking about eligible patients, we're really looking at the patient's relationship with the covered entity and not necessarily their ability to pay. It's not a needs-based program for that person. It's really more the covered entity's relationship with the patient. Something that we'll get into a little bit later in the presentation, but HRSA, when looking at the definition of patient, they have been applying the definition to require that the prescription drug order arises from the healthcare service provided by the covered entity's healthcare provider. So, I'm a patient, I go see my doctor that's employed by this covered entity. I'm issued a prescription as a result of that encounter. This has been thrown a bit up in the air as a result of the Genesis case, which has added some confusion around this point. But we're going to be circling back to that a little bit later in this presentation. So one last point on eligible patients before we move on, and that is, when a covered entity dispenses a 340B product to a patient who's not an eligible patient, that's considered diversion. So you'll hear that term thrown around. All right, I think we touched a bit on this earlier, but just to recap, the covered entities are essentially saving revenue, saving money through purchasing these discounted drugs, realizing revenue when they're reimbursed at the standard payer rates for those discounted drugs that they've purchased. And what's interesting is, that results in millions and millions of dollars for some of these covered entities, and there are no statutory restrictions that kind of govern how covered entities are required to use those funds, at least not with respect to the 340B program itself. you know, again, the legislative history shows that the intent there is to help these safety net providers stretch their federal resources and greater serve these patient populations, but there's no affirmative requirement in the statute that money be spent in any particular way. Some covered entities, such as grantees, may be subject to contractual obligations that require them to spend their 340B savings, you know, in accordance with the terms of money received under their grants. But as far as the 340B statute itself goes, again, there's no restrictions on the use of funds. Oh, going back to in-house pharmacies, these are pharmacies that are owned by and are considered a legal part of the covered entity, of the 340B entity. Typically, these in-house pharmacies are listed as the shipping addresses of the entity, and the entity owns the pharmacy license. There are also contract pharmacies that participate in 340B. These are pharmacies that enter into agreements with covered entities to provide services and dispense the covered entity-owned discounted drugs to their patients. These really operate as like a bill to ship to arrangement, where the covered entity is the purchaser and they are the bill to, and the contract pharmacy is where the manufacturer delivers the product and is they shipped to. As far as a bit of history on the role of pharmacies in the program, originally only in-house pharmacies could dispense the discounted drugs to 340B eligible patients. This was expanded in 1996 to allow those covered entities without an in-house pharmacy to use a single external pharmacy, aka a contract pharmacy, to dispense those 340B drugs. Then in 2010, you know, the program really expanded, where the Affordable Care Act began allowing covered entities to contract with an unlimited number of contract pharmacies. And contract pharmacies are required, again, they must be registered for the program. They have to be listed in the Office of Pharmacy Affairs Information System database. And typically they have a written contract signed, contract for pharmacy services with the covered entity in place that kind of governs the provision of services there. All right, just to confirm, Rebecca, is it on the next slide? Okay, great. So let's talk a bit about the contract pharmacy obligations. But before we get into that, let's talk about the covered entities obligations. So there are a number of responsible things that covered entities have to comply with under the statute. Covered entities are the ones who hold responsibility for compliance with the program's standards. And typically we'll see these flow down to the contract pharmacies through those written agreements. But first, let's run through them briefly. And so under the 340B program, these covered entities, they have to provide oversight of their contract pharmacies, make sure that they're operating correctly and doing the things they need to do to ensure compliance with the program. They have to audit their contract pharmacies, and they have to make sure that they're maintaining records auditable by HRSA. And lastly, covered entities have to report non-compliance and corrective action plans to HRSA when instances of non-compliance with program requirements are discovered. All right, so again, contract pharmacies have these contract pharmacy services agreements that they enter into with the covered entities. They're contractually obligated to comply with the terms of those service agreements. And as I mentioned earlier, what we typically see is the flow down of the compliance obligations faced by these covered entities down to the contract pharmacies. And really you'll see a large focus on the inventory management and the prevention of diversion. So making sure that your contract pharmacies are managing inventory, keeping adequate records, tracking, accurately and completely the dispensing of 340B stock, and making sure that those drugs are not being diverted or going to ineligible patients under the terms of 340B program. So contract pharmacy obligations, we mentioned that there are these written agreements between the contract pharmacies and the covered entities. And HRSA has released some guidance on, what should be within these agreements. They have not provided a model contract. I think under the rationale that there are far too many types of covered entities and far too many types of pharmacies to really put together a single document that would be suitable for everyone. But they have provided examples of contract provisions, set forth in a 2010 rule. And they've also kind of, touched on what these contracts really should cover. So some of those HRSA suggested sample contract provisions include provisions that require pharmacies to compare the 340B drug shipments that they receive to the orders that have been placed, and making sure that those are aligned. And if there are any discrepancies, to inform the covered entities of those discrepancies. We've seen contract provisions where pharmacies are required, again, maintain readily retrievable business records, making sure they have a tracking system to ensure that the 340B product is not being dispensed to ineligible patients. And we're also seeing contract provisions that pharmacies are allowing the covered entities access to those medication tracking systems and the audit opportunities. As touched on in the previous slide, covered entities need to make sure that they have oversight and are auditing their contract pharmacies. So we see provisions within the contract pharmacy services agreements to that effect. And lastly, and perhaps the most important point, that pharmacies only dispense the covered drugs to eligible patients. All right, so you'll see that the diversion is really the key factor and the key responsibility here, and making sure that these discounted drugs are actually being dispensed to eligible patients, and trying to avoid diversion, trying to maintain management over the inventory is really important for pharmacies here. And so there are kind of a few ways that diversion can happen depending on the type of covered entity at issue. But, for example, a hospital may have an instance of diversion where 340B stock is dispensed to an inpatient, or they have 340B stock that is dispensed to a patient who's written a prescription by a provider who's not employed by the covered entity or contracted with the covered entity. Those are some instances of how diversion might happen. And you'll see that managing the inventory, it's really handled there are two primary models. Physical inventory system and the virtual inventory system. Currently, virtual inventory or replenishment model, this is the model that's more popular. We tend to see this more frequently. Whereas, the physical inventory system, it's physically two separate inventories. We've got physical stock, one shelf, or a couple shelves holding our 340B discounted drug product. And, a separate shelf holding non-340B product. So it's physically separated, tracked, and kept separate. It's not commingling with any of the non-340B product. Under the virtual inventory model, however, it's tracked virtually. So you have discounted product that's purchased commingling with non-340B product. And you tend to see these models put into place because you don't have to keep separate space. You can have the drugs in the same space, It can help keep your inventory, costs down there. And all of the tracking is done virtually. So there's tracking on when that product is dispensed and making sure that it's all aligned. And some other, I guess, positives to the replenishment model are it's not, the product's not necessarily treated differently than other product because it's all kept together. So you don't necessarily have to have separate policies in place for handling of that product, when you take it off the shelf. And I would add the other item, that is also coming into play here is, making sure that everything is tracked properly. We want to make sure that, we know which drugs are being purchased, which drugs are being dispensed, and all of that is being tracked virtually and captured through your virtual replenishment model. So with that, I think we'll shift over to Rebecca, and she's going to walk us through what we're seeing now in the legal space as far as program developments go and the impact that they're having on pharmacies.
Thanks, Renee. And I will say, a lot of this is going to call back to the discussion of who is a patient, who is eligible. But I think that Genesis Healthcare in particular is worth spending some time on because it has both possibly expanded how 340B drugs can be dispensed, but also I think put a lot of confusion in, particularly when it comes to inventory and who is an eligible patient. So I'm going to spend a little bit of time on the case. Because I think, cutting to the chase, I think the answer is really less clear after Genesis than it was before. So we'll see what happens in the next few years. Just a reminder of the statutory language. The covered entity shall not resell or otherwise transfer a drug to a person who is not a patient of the entity with no definition of patient. And Renee mentioned that HRSA in 1996 provided a definition of patient. Genesis was a federally qualified healthcare facility. HRSA did an audit and determined that they did not have appropriately auditable records and temporarily banned them from the 340B program. By the time the lawsuit came about, HRSA had reinstated them, but Genesis argued that the case was still live because there was still a question of who they could dispense to. And the court looked at the intent of the 340B program, which we've talked about, and people's general understanding of the word patient. And the court said that HRSA's definition that we went through earlier was inappropriately narrow, and it was contrary to the plain language of the 340B statute, which said patient, and it would frustrate the goal of the 340B statute, which is to make covered entities profitable in the face of prescription drug price increases and to stretch the federal dollars that were helping fund them. So the court said that this definition of a patient was inappropriately strict, that a patient could in fact be, for example, someone to who Genesis was dispensing prescription medications as the only medical healthcare provider interaction between them. However, the decision is only limited to Genesis and this instance, so it is not clear what HRSA will do in another case. And the court did say that HRSA can issue a restrictive definition as long as it is consistent with that intent. So HRSA could come out with a new definition of patient, and it could possibly be restrictive again, as long as it looks at the intent of the 340B statute in making that definition. So we don't know whether that will happen or not. What I think is important to think about in terms of where we are after Genesis is there is a room for much more dispensing of 340B medications to eligible patients. Who an eligible patient is probably much broader, at least for now. But there's also a lot of confusion for who is the applicable contract entity for a contract pharmacy that is dispensing a prescription. It's not unusual for a patient to go to more than one eligible healthcare provider to get their care. So I think that this makes inventory and tracking and your agreement with a contracting entity really important so that it's clear whose patient is getting that prescription and therefore whose 340B drug that is. Another recent action by HRSA was to make much more simple and hopefully fast-acting the administrative dispute resolution process. The new rule, it can be used for claims by contracting entities that they have been overcharged for medications by manufacturers, or any limitations on purchasing 340B drugs from a manufacturer. And it can be used by manufacturers only after they have done an audit. They have to do an audit of the contracting entity first, but they can then complain that the contracting entity has violated the diversion rules, for example, dispensing to someone who is not a patient under whatever definition is currently active, or that they're using duplicate discounts. And the new administrative dispute resolution rule will decide those matters. The roster is made up of Office of Pharmacy Affairs staff. There'll be a 3-member panel. They can issue final agency decisions, but those can then be, you can make a request for reconsideration to the HRSA administrator, who can either reject the request or support or supersede the panel decision. The OPA director, the Office of Pharmacy Affairs director, after that action is final, can determine whether corrective action is needed, and can refer it to the Office of Inspector General for any possible civil monetary penalties. I'm going to go quickly through these next 2 slides. It's just to give a flavor of what's happening right now in Massachusetts. There were several bills trying to protect the ability of federally qualified health centers and safety net hospitals to purchase discounted drugs, and trying to stop drug manufacturers and distributors from restricting how these are used. There was also language that would protect those contracting entities from discrimination. I say was because the legislative session just ended. A fairly large pharmacy bill passed the Massachusetts legislature at the very last minute of the session, which did not include any of the anti-discrimination laws in there. Senator Piano, who proposed this one, the S704, has said he will refile because he's still trying to protect patients as well as the disproportionate share of facilities. But we will see whether there's appetite, given the large pharmacy bill that just passed, whether there is appetite to go forward and do something more. And at the same time that we're trying to protect patients and covered entities, I'll also note that Mass Health, as an insurer, is trying to prohibit what 340B can be used for. They have notified their managed care entities that they will no longer pay for the weight loss drugs that are very expensive. And similarly, they will not pay for 11 high-cost cancer drugs purchased through the 340B program. Mass Health pointed out that they will reimburse the providers the actual acquisition cost for such drugs, so they will not lose money on these drugs, but they also won't be able to take advantage of the 340B program for them. And this is all so that Mass Health can stretch their own dollars. So we'll see how this plays out. People are not terribly happy about those restrictions. And finally, just in terms of strategy, I'm going to speak briefly and then let Renee take over again. We think it's really important that you regularly review and update your policies related to 340B drugs. Make sure that your agreement with covered entities is clear, that you know which drugs are covered, who the eligible patients are that you're covering for them. Make sure that your inventory management systems make that clear so that if there's an audit, you can clearly point to the path, and ongoing staff training and education. Renee?
Yeah, I'll just amplify a couple of the points that Rebecca here made. With Genesis in particular, and I think you mentioned this, Rebecca, it's going to be really important to make sure, if that more expansive view of patient is adopted, beyond the specific instance with Genesis, that pharmacies are, able to track, who the patient is, who the covered entity is, the drugs at issue, and that's going to cause a lot of, I think, confusion and potential for, maybe mishaps in record keeping. There could be an inadvertent diversion. So those are things to really keep in mind with that Genesis case, from a pharmacy perspective. With respect to the ADR rules, while those are really focused on the dispute resolution process with the covered entities and drug manufacturers, you'll see, again, the big issue is going to be diversion. If there's a pharmaceutical manufacturer audit of a covered entity and they find, oh, hey, we think you've been diverting drugs. We think there's been diversion here in proper dispenses to ineligible patients. Then, that a lot of that's going to come back to what does the record keeping show, at the pharmacy and the covered entity level. So making sure that there are those clear policies, that you've got, those robust inventory management systems, with clear defined procedures in place, and making sure your staff are aware of how they're supposed to be tracking these things, of what the dispense tracking system looks like, and what goes into play there. Because again, 340B it's a hot topic right now, as evidenced by some of the Massachusetts legislation Rebecca touched on, but we're seeing that in other states as well. I'm based in Colorado. The Colorado legislature just introduced a bill to aimed at protecting 340B. That was kind of spearheaded by the Colorado Hospital Association. So we are seeing a lot of efforts to bolster the program, with covered entities wanting to make sure that they're protecting that revenue source. And I think as pharmacies, it's going to be important that, if we're seeing expanded action in this area, if we're seeing increased dispensing, increased purchasing, that we're just aware of the potential compliance considerations, making sure that, again, the contracts are being adhered to, and that everyone's aware of the obligations that fall under those, and whether that's, having policies in place, conducting staff and education training, working with your covered entities to make sure that there's a clear understanding of the division of responsibility there, and who is responsible for what. Those are just some of the strategies that pharmacies can take to, put themselves in a good position for potential increase in 340B dispensing and contract pharmacy arrangements. All right. Rebecca, do we have one more slide?
Just the final slide. And we have 10 minutes for questions if people have any. somebody asked, how often are audits done? Who requests the audits? Who performs the audits? Who receives the findings of the audits? It's a great question. There's several different kinds of audits. The drug manufacturers can audit what they're doing. HRSA can audit any contracted entity. Renee, you want to add anything about timing of these besides
Yeah,
complete
so,
responses?
I mean, HRSA can do audits. You'll see under the contract pharmacy service agreements, that's typically an included clause in those contracts that the covered entity can audit the contract pharmacy. So, while that's not necessarily a HRSA audit, it's a contractually obligated audit that will fall on the pharmacies. And then, as Rebecca mentioned, HRSA may do audits of the covered entities to ensure that they are doing things like that they're appropriately registered with HRSA, that they are keeping track of their records. They'll look at claims for potential diversion, things like that. So as far as who receives the findings of those audits, it's going to depend on the nature of the specific audit. But if you have a HRSA audit, then the covered entity is going to be receiving those findings. If you have a audit by your contract entity of the contract pharmacy, then those are the parties that will be involved there.
And the consequences of an audit really depend on what it is. Many of the HRSA audits, if it is found that a covered entity, contract entity, has been using the program in an inappropriate way, what they will have to do is pay the manufacturer back for the regular cost of the drugs. So it's expensive, but it isn't particularly punitive in a case like that. If it's a good faith error, for example, what you want to avoid is something that looks like purposeful abuse of the program, which is when there could be civil monetary penalties.
Yeah, I think what we see is there tends to be the position in the industry that for your covered entities, there can be great benefit at relatively low risk for participating in the program, because HRSA, the enforcement and penalty provisions are relatively sparse.
The next question is, do you have any thoughts on whether 340B medications can be excluded with the new administrative executive orders, i.e. around gender affirming care? It's a great question. I think it remains to be seen. I don't think I'd want to make a bet yet on whether that would stick. How prevalent is the 340B program? How much does it help the disproportionate share hospital? Renee, you want to take this?
Sure. I mean, so the program is definitely become much more expansive in recent years. We've seen a huge increase in the amount of purchases made of 340B product. As far as how much it helps the disproportionate share hospitals, I mean, it's going to depend on the hospital, but these are, I mean, in talking millions of dollars here of money that's being saved and then brought in through reimbursement, so under the payer program. So it's not an insignificant amount of money, and we're talking about safety net providers with the disproportionate share hospitals, with grantees. Often these are providers that are operating on thin margins. So I think in that position, you see a lot of reliance on the 340B program in getting that revenue. So, again, how prevalent is it and how much does it help? I would say it's pretty prevalent, and how much it helps is going to depend on the specific provider and what their patient population looks like. Again, because we are talking outpatient drugs, it's an outpatient drug discount program rather than an inpatient program. So I hope that answers some questions.
Um,
A bunch more, sorry, didn't even
Yeah.
see that.
Do you see the manufacturers opposing the use of 340B drugs in a covered entity for patients that have insurance? Yes. Yes. They're not fans.
Right, and I mean, and for patients that have insurance, I mean, that's really where the covered entities see their savings, right? As they're purchasing at a discount and getting reimbursement under those health insurance plans, you know, at the full reimbursement rate. And so, yeah, I agree with Rebecca there.
The 340B discount doesn't pass on to the patient, correct? The hospital charges as if they acquire the drug at full price.
Correct. So it does not pass on to the patient. You know, it's a savings that is realized by the covered entity. And again, the statute's very sparse in how those savings have to be used. There's nothing in the statute that requires them to directly pass that savings on to the patient. And it's not necessarily even a needs-based, you know, qualification. So yeah, it's charged as if they acquired the drug at the full price. That's right.
Regarding Mass Health not covering the weight loss drugs, where is that information available? You can search for Managed Care Entity Bulletin 109, which was issued in January 2024. Managed Care Entity Bulletin 109. And I will say that they originally issued it in January. They actually delayed the start of that till April 2024 because of objections to it. But it is now their policy.